for this session. All right, we've got a few minutes here for questions. So any questions from the audience for this section of our speakers? Feel free to come on up to the microphone or pop your hand up.
President, I have a question for Mark.
Sounds good.
So I have a long interest in sternocleidomastoid joint injuries. And in the past, I think that we've said, you know, if we leave them all alone, you do okay and the functional deficit is not too bad, which I think was false. I think what we should have said is that we don't really know what to do for this. It's a scary area, and we don't have a good operation, so we're just going to leave it alone and hope for the best. I think that's what we should have told patients. I think a lot of patients have significant pathology in that joint if it's not treated initially. So I'd ask you this. If you had a young trauma patient with an anterior dislocation of their SC joint, what would you recommend for that patient?
So that's, there's been a lot of studies looking at young, healthy, active individuals, and so sort of long-term, they might have a lot of complications if the joint is left unreduced. So, you know, prominence, instability, they might not be able to go back to their function. So I'd have a discussion with them just in terms of stabilizing and reconstructing the joint. Sometimes it can be a little bit hard to keep it reduced. So I would talk to them about the different sort of surgical options and then just have a really thorough, informed consent with them.
If they said to you, should I have an operation on this joint, doctor, yes or no, what would you say?
Maybe.
Do you have an answer, Mike? This is a very hard question to answer because here's the problem, right?
Not
I
for
went
me.
through the.
I say yes.
Okay. So the problem is this, right? We know that most of them do well, but when they don't do well, if we treat non-op, we don't have a great solution to take care of them later down in the line.
I have to disagree. If you have a young active trauma patient and his clavicle sitting on top of his sternum, he does not do well if you leave it like that. Period, full stop.
So this is the next clavicle?
No, I'm not saying that. What I'm saying is if some of the CTs that you showed, the clavicle sitting on top of the sternum, a young active patient, there's no way that guy's going to be happy if you leave it like that. And I see those patients late. It's much, much more difficult late than early. Absolutely much more difficult.
So you're suggesting that the primary recommendation for acute anterior dislocation of an SC joint in a young, healthy patient should be surgery?
Yes.
Okay.
I think it
I
depends
have a
on the
stronger
amount.
argument now to tell the patients.
I think it depends on the amount of, like some of them are just subluxed a bit, but some are frankly dislocated. So the frankly dislocated one, I agree, we should probably be more aggressive. But the ones that are just a little bit unstable, they're in place, maybe they're a bit subluxed, that's different. I think the majority are subluxed, not frankly displaced.
I agree, but I'm talking about the CT that you showed with the clavicle sitting on
yeah.
top of the sternum. That needs an operation, I think.
Which surgery you did?
I reduce it first, and then in my experience, closed reduction in general has been unsuccessful, and I usually, if I'm going to the OR to reduce it, I usually am fixing it in some way, either with a suture technique or occasionally or like plating across on the sternum, and that plate comes out at 12 weeks before it starts to loosen.
So Dr. Bainey, I'm going to come to you. I just want to ask the panel, in that situation, what is your vascular thoracic support and how do you quarterback that going with these patients?
So I preponderate, and so the thing is, there's a gradation of risk here. The best ones are the acute anterior ones, and then the late anterior, chronic anterior ones, and then the acute posterior ones, and then the worst are the late posterior ones. And so if you go down that gradation, then the more nervous I am, especially if you have to dig a clavicle out that's been in there for a while posteriorly. So I prep and drape the whole chest. I have a couple of units of blood typed and crossed. I have a vascular surgeon next door who knows I'm doing that case. He's not in his office across town. He's in the house, and I let him know we're doing that case. And I say, if I come and get you, it means that I need you immediately, right? And so that's clearly set.
That's great communication. I just wanted everyone to hear that because I think that's a really important point in these injuries. Dr. Bainey.
Yeah, I have a question on the clavicle. When you were talking about some of the young, healthy patients that sometimes even request it to be surgically fixed because they want to get back to activity quickly, how often do you end up finding out that they also want their plate removed later because they're aggravated for wearing a backpack or military, those sorts of instances where...
Yeah, I think the default is to remove the plate afterwards. But like I said, I have patients who come, they have full motion, they have no impingement. Mm-hmm. And sometimes I have a hard time convincing them to have it taken out. They say, hey, well, it doesn't hurt. Why should I take it out?
Yeah, and when do you usually do the removal then? Or what's your indication
removal
to do?
4 or 6 months after. Okay. Yeah.
Thanks.
Yeah.
Question, please.
When would you consider doing a shoulder orthoplasty, as most of the reverse shoulders results are getting better and better. Most of the company have a fracture stem, and some elderly patients that without going to second, third surgery, you just go and do primary reverse shoulder.
I think there's an increasing role for reverse arthroplasty. I'm going to talk about that this afternoon specifically. There's a couple randomized trials out now looking at older patients who obviously need some kind of surgery for badly displaced fractures, looking at ORIF versus reverse arthroplasty. The more complex the fracture, the bigger the benefit is for arthroplasty. So if you look at the C2 and C3 fractures where the head's 3 or 4 pieces, then reverse arthroplasty performs better in general than fixation. So the older the patient, the more complex the fracture, I think there's a bigger role for arthroplasty, as well as certain specific situations where the head is completely dislocated, the iatrogenic one where you shear off the head trying to reduce it, and we talked about that the other day, the ones with a very small soft tissue attachment to the head, et cetera. So the more complex the fracture and the more older the patient, I think the bigger the role for reverse is these days. And there are multiple different companies with great prostheses now to augment your thing in that kind of situation. I know, Utku?
I agree. I mean, it is usually the fracture pattern that dictates, and the older they are, the fracture is more complicated. I think if it's not a easily fixable and very community fracture in an elderly, and define what is the elderly, and with or without comorbidities, the age may change. If there's an indication for surgery and you are over 75, usually the fracture is comminuted. My indication is reverse shoulder. Although I may be able to fix it, it is more reliable that the reverse shoulder is going to give them better outcome. I have a question for you because you discussed the options of the surgical for the proximal humeruses with deltoid split. I think if you have a deltoid split and you need any revision surgery after that, even removal of hardware, you should not try to go through the same deltoid split approach because the nerve is super hard to identify. I think you should go, DeltoPAC is okay to have an incision, DeltoPAC after a deltoid split. I don't think it's a soft tissue problem. What do you think?
Yeah, it's a difficult situation. So I try and look at the particular case and see, can I get those, if they're posterior screws and such out, can I get them out through a deltopectoral and just stay right on top of the plate and just let everything else as a sheet off, because then it makes everything easier. I've gone both ways, and I agree with Utku. It's very hard to find the nerve if you've gone through the nerve once before. So, and I don't, the second time around, I don't usually find it. I usually, do my dissection up top, do my dissection down below, and just elevate that area in between and stay away from it, essentially. But it's a hard situation. That's my consideration now when when you're fixing a fracture. Two things I think we've done in the past that have hurt us for arthroplasty. One is putting a big fibular strut down the canal. That's awful when it heals and you're trying to do an arthroplasty, or doing a deltoid split. Those two things hurt your second shot. So I'm very leery about doing those now.
And one final question here from the audience.
Two questions, both sides of the clavicle. SC joint, posterior dislocation locked, neurovascularly intact. Trauma 3 center, your closest trauma 1 or 2 is an hour away. No vascular surgeon at your center. Do you try to reduce that or ship it?
Personally, I would ship it. I wouldn't do it. See, the thing here is not, you don't have to do it yourself. You just have to recognize something should be done and send it to the appropriate person. And you may be perfectly capable of doing that, but you don't have the backup to do it. That's the key thing here. And so, fortunately, catastrophic injuries are very rare, as Mark showed in his thing. But if it does happen and you don't have someone to help you, you're basically dead in the water. So I would not do that unless I had someone available. And 95 times, 99 times out of 100, you're going to get away with it. It's not an issue. But the one time where you don't, you need some support, and be a very lonely thing if you didn't have someone in your house to do that.
There's no urgency to necessarily ship them right away, but the problem is if they're that far away, you send them home and they won't get to that person a month later, to the right person. So they should be seen as soon as possible, but you don't necessarily have to put them in a helicopter and send them down.
And then the other end, the AC joint. Is there literature to support doing a tightrope alone without a soft tissue reconstruction?
So if it's an acute injury, you can do tightrope alone. So if it's an acute injury, and acute is less than 6 weeks, the theory is if you mechanically get the clavicle back where it is, the acute inflammatory process will things will scar in, and you'll be okay.
Within a 7-day window kind of thing?
Well, 6 weeks is, considered acute. After that, there's no inflammatory reaction. It's kind of a cold biologic environment. So that's when you want to augment with some kind of biology.
So you'd use a tightrope all the way out to 6 weeks?
I don't use a tightrope. I use plate.
The hook plate.
Yeah. So, I think tightrope definitely has a higher risk of failure. They displace more. But still, in the first few weeks, you could just do a tightrope without biology. But, there's no good solution. So people do a variety of things, kind of a sign that there is no good way to do it.
Again, the differentiation is the acute versus chronic. Again, 6 weeks or something like that. In acute ones, I don't think reconstruction is the right thing to do, to tell the truth. The risk of complications after reconstruction is significantly high. I would use the tightrope only in acute fractures, but you got to be careful what you are looking for, right? So hook plate is more like not dependent on the patient compliance too much. You put the hook plate, you do the right surgery. Usually you can let the patient do full range of motion without a sling, etc. If you do the tightrope, the weak link is where the suture friction that holds the things. You got to hold that patient a little longer. That's what I talk to the patient. I tell them I'm seeing it for 10 minutes or 15 minutes. You know yourself better. If you can be compliant with being a little slow, I will give you the tightrope, no risk of second surgery, and I have good success with that.
When do you start moving them? If you just do a tightrope?
It's not the move, so I move them right away, but I keep them in a sling for 6 weeks.
So sling for 6 weeks?
Yes.
How do you move them if you're in a sling? What do you
So-
mean? Like in a sling they're moving?
No, you take out, do your exercises during the day,
Right.
but if you're not doing your exercise, it stays in the sling.
Okay.
Perfect.
Got it.
Please join me in thanking our panelists for a fabulous section.